So, good afternoon, everyone, and welcome to today's webinar, which is hosted by the Refugee Health Program at the Global Health Institute at AUB. My name is Hadi, and I work as a consultant at GHI. I will be facilitating today's discussion on post-war mental health considerations for internally displaced individuals in Lebanon. So, as we all know, conflict and displacement leave profound impacts on multiple levels for affected populations. And the recent war escalations in Lebanon have forced hundreds of thousands of individuals to be displaced within the country, which added another layer of hardship to an already fragile context. Because this war followed a series of major challenges that Lebanon has faced in recent years, including a severe economic collapse, the Beirut blast, and other ongoing social and political instability. So the compounded impact of these events has taken a significant toll on mental health, especially for displaced populations, which makes today's discussion more critical than ever. So today we're honored to be joined by two distinguished mental health experts, namely Dr. Tanya Boski, who is an associate professor of clinical psychology at AUB, and Dr. Fadi Malouf, who is a child and adolescent psychiatrist and a professor and the chair of the psychiatry department at AUB-MC. So both of them have made valuable contributions to improving mental health care in Lebanon through their clinical practice and their research. And today, they will be sharing with us their insights into the mental health challenges faced by displaced populations in Lebanon after the war, along with current response efforts and strategies to support resilience and to improve mental health outcomes during these challenging times. So thank you all for joining us. And I now give the floor to Dr. Tanya Boski.
Thank you so much for the introduction. Very much appreciated and really happy to be here to share some of my experiences, but also to learn from you. So I look forward also to some time with Q&A. So I'll start the webinar by talking a bit about the more collective side of mental health and the impact of the collective nature of war and of displacement on mental health. And I wanted to start with an image, a cartoon. And I'm sharing this because we see here a very stressed koala in a habitat that has been destroyed. And we also see these humans coming from outside and looking at the individual koala and saying, well, this koala clearly has a mental health problem. And I start with this really to point out the clear impact that the environment, that the collective nature of war, of displacement has on an individual, and that therefore we need to think from a collective perspective and a systemic perspective in all of our initiatives and attempts to support people during and after conflict. So I wanted to start with a quick question for you to get a sense of the audience here. We, of course, can't go through all introductions, though I would love to know you all. But if you could just raise your hand if you have had an experience of displacement or you work with people who have been displaced in your current work in this war or previous wars. And I'm scrolling through now because there's so many. Okay, it's more than half. That's helpful to know. And so I'm going to focus on displacement and start just talking about the broad kind of public health literature on war and displacement. So we look really broadly. What we see is intuitively it makes sense. We would see, based on this WHO data, this huge difference between those who live in conflict settings in terms of their mental health. This is an example for depression. and the global average. And so here we have not incidence, but we have years lived with a disability. So this is really about quality of life affected by depression. So you see this huge difference, which makes sense, that very much higher, statistically significantly higher depression amongst those living in a conflict area, even after controlling for all other individual differences that we might expect to see, gender, for example. But what we also see is we see this very large confidence interval. So these lines in between, and some of these you see for the older age groups at the right end of the graph, we see particularly high levels of depression, and we see this really large variability. And we see this also for anxiety compared again to the global average. You see this very, very large variability across different contexts, largely because of differences in the conflict type, level of displacement, multiple displacement, and so on. And when we take a cross-sectional picture of this, what we see is that the prevalence rates of depression and anxiety, of post-traumatic stress disorder, of schizophrenia and bipolar, ranging from 22% for depression to 13% for PTSD and 5% for schizophrenia and bipolar disorder. So we see that these are all much higher than the global averages. And we also, to say here, these are clinically diagnosable conditions. So we're not capturing here another whole host of people who may have subclinical symptoms and distress. So it's much higher, but we also see that it's including here things like schizophrenia and psychotic disorders, where we would expect to be around 1% to 2% of the population, and it's over 5%. So it's not just mild to moderate depression, anxiety. We're talking about more severe presentations, and we're also talking about severe and enduring illness being much higher in these contexts. So when we look specifically at displacement, there are a lot of different studies in lots of different contexts, and I've just given you a snapshot here of some of those studies ranging from Palestine to Afghanistan to Cambodia to Sudan, looking at displaced people, internally displaced or refugees, and the prevalence of mental health difficulties. And we see, again, huge variability. So when we look at PTSD, there's a range here from 3% to 88% of the sampled population meeting criteria for the disorder. We have depression, 5% to 80% across these different studies. Anxiety disorders, 1% to 81%. So these are just huge ranges. Really large variation. And why might that be? One of the main reasons is, of course, methodological differences. So there may be differences, for example, in interviewing participants versus screening. We tend to get higher rates when we screen versus interviews. But there's also likely to be differences across these contexts. So the level of exposure to violence, multiple displacement, and other kind of conflict-related reasons. One of the other really big reasons is around the sequelae of what it means to be displaced and the impact that that has on pre-existing stressors and the exacerbating effect that it has on disadvantage. So when we look at the literature, what we find is that factors like poverty, like social exclusion, community cohesion, social capital, racism, discrimination, prejudice, low income, unemployment, even things like having electricity and running water, owning your own home versus renting, having your own car. All of these types of factors are significantly, consistently associated with poorer mental health across contexts, across age groups, across the lifespan, across cultures. So these are really key factors that play into poor mental health and are severely exacerbated by displacement. So now I want to zoom right into Lebanon. And I wanted to share some data that we collected from adolescents and their families, some of whom had been displaced, and their experiences of their own mental health and the impact that their environment was having on their mental health. And so we took a systemic approach. We interviewed the whole family, as well as the individuals within that family, and we asked them about the onion model systems around them, the social ecological model you can see here that looks at the different systems around the child. So firstly, within the adolescent, of course, we saw what we would expect to see: depression, anxiety, hopelessness, stress, anger. We saw dahat nafsi, the psychological pressure, this wonderful term that describes the external pressure on the internal mind, as well as loss and grief. But we also saw amazing coping through optimism, determination, hope, through the determination to continue to make ends meet, to find opportunities to live, as well as faith, and all families describing this active patience or sabr, this really important mechanism of tolerating and containing the stress of a really difficult and adverse and unfair situation, and managing not to fall into total hopelessness, but also not fighting so hard that you exhaust yourself. So being able to tolerate adversity. So we saw that really clearly in the individual, but we also looked outside the individual. And so at the family level, what we saw was some wonderful examples of really close family relationships, of nurturing families, of close sibling bonds, and good parent-child relationships that were really protective for mental health and improved coping. But we also saw some really negative, unhealthy family dynamics where there was violence, abuse, dysfunctional family functioning, and other really difficult relationships, punitive parenting, and things like that were impacting on adolescent and parent mental health, as well as different family roles that were really challenging, and these are very gendered. So we saw, for example, that men would feel a lot of pressure to provide, and so when that was really challenging because of displacement, because of the economic crisis, because of unemployment, that they would experience a lot of shame and humiliation. And we also saw that women would describe feeling that they have to be the kind of emotional containment of the family, the emotional regulation of the family, and that was really burdensome. And then for girls and boys, we also saw differences, for example, in girls, unpaid labor, and boys needing to make money outside, and all of the things that exposed them to at the community level. So when we look more at the community level, we see a lot of really big challenges. One of the main ones was social isolation, and people feeling that they couldn't connect within their communities. The communities were really disjointed and fragmented by displacement and by lack of resources. And so we saw people being very, very isolated within an otherwise functioning community. We saw a lot of discrimination, harassment in the street, neighborhood violence and conflict, and then parents wanting to protect their children, particularly girls, and keeping them inside, which increased isolation. And so this is a really challenging environment also for the parents. So we saw this impact on parenting capacity and ability to parent in the way that the parents wanted to, and that impacts on both the parents' mental health and the adolescent. And then we saw in the macro level within the society, all of these major social determinants of mental health: poverty, exploitation, unemployment, paid and unpaid labor for children. But we also saw the structural side, so things like lack of access to education, or issues in education starting, and inconsistencies in access. We saw issues with the healthcare access, receiving aid equitably, and also some systemic and structural state policies that discriminated against some people. So within this context, we saw some major differences, cross-cutting influences here: nationality and gender. I've described some of the gender differences that we saw, but we also saw some nationality differences depending on the community and depending on who had been displaced, and whether the person was from Lebanon. So, for example, Syrian refugees experiencing more systemic structural discrimination from the macro system level. So it's a really challenging context that people are trying to navigate. I wanted to think about, in this really broad collective adversity, what might mental health support look like? So for those of you who are not familiar, I think many of you will be, but the IASC intervention pyramid is widely used in Lebanon to inform mental health care and allocation of resources. And it's really designed for humanitarian disasters, for war, for displaced people, with the assumption here that at the very top of the pyramid, there will be those who need specialized services, but that there's also everybody else. So thinking of those kind of the 80% that we saw in the prevalence rates, where maybe these are not requiring specialist services, but this is a kind of a normal reaction to an abnormal collective experience. And so other types of supports can be useful at the family level, at the community level, and that some of these, given that we have very few resources, can be delivered through other sectors, through non-specialist providers, through a task shifting model. So this has a potential to, as you see at the bottom of the pyramid, to address and strengthen community and family support, as well as basic services and security. Some of the challenges that we've experienced in trying to deliver this, and I would love to also hear from your experiences of this, is that some of that more community, family, basic services interventions require a lot of cross-sector working, and that we tend, particularly in mental health, to work in a silo. And so the structure of mental health care and of sectors in general doesn't easily allow for cross-sector working. I think that's improved a lot over the last couple of years, but still has a long way to go. The other issue that we face, particularly as researchers, is that the evidence base for these tier 1 and 2, the bottom 2 tiers, is quite poor and actually very difficult to do from a research perspective, because it's much broader, it's a larger segment of population, they're less manualized intervention, more difficult to run randomized control trials. And so we see less funding for these types of interventions, and we just see less research being done in general. And that's very difficult then to use evidence-based services and interventions when there's just a lack of evidence base there. The other issue that we face is that it's very challenging to scale up interventions that do exist. It's hard to find feasible ways to make sustainable, contextually relevant, evidence-based care last and get integrated and adopted into existing services to reach a much larger proportion of people. And these challenges are really important that we work towards addressing them, because these are the ways in which we might be able to address the underlying structural causes of disadvantage that fuel poor mental health, particularly in the context of displacement. So I wanted to give a couple of examples of attempts to go beyond a kind of sticking plaster. If we go back to the koala metaphor, that the koala, if we just try to address its individual symptom and not the fact that it's alone and that it's lost its habitat, that it's going to be limited in its effect. So I'm going to give 2 examples. The first one is called Sawa'ahwa. It's a family intervention, meaning stronger together, specifically developed in Lebanon for adolescents, at-risk adolescents and their families in Lebanon. And the idea of this intervention was to address the wider family system around adolescence. The theory of change is that if we can address family functioning, so although it's a mental health intervention, the idea is that if we address family functioning, then we can improve the environment around the day-to-day environment around an adolescent and the parents, and create a nurturing environment in which their mental health can be protected and promoted. And so we would expect to see other positive impacts on both the adolescent and the caregivers as well. So I've put a QR code here for more information on that. But I just wanted to tell you a little bit more about it. So this is a 7-session intervention that was delivered in homes or communities, whatever the preference of the family was, by non-specialist providers. So this was a focused psychosocial support intervention delivered by case managers or social workers trained in the intervention, and delivered in Lebanon, in Tripoli, and in the North Bekaa. And the idea of this intervention was really to focus on the family. So these were full family, whole family sessions. And this is an example from a family that shared with consent through TDH, an example of an activity in which the family are doing some problem solving, working on their skills of cooperation and communication. So this was the focus of the intervention. So we did a randomized control trial of this intervention with 350 families, and we found evidence of effectiveness for adolescent and mother-reported family functioning. which was our primary aim of the intervention. We also found for those adolescents who completed the intervention improvement in well-being compared to the control group, as well as caregivers' mental health and well-being and caregiver-reported parenting. And when we split those between the gender of the caregiver, between mothers and fathers, we found the same results. So this was impacting positively on fathers as well as mothers. So this is really an example of attempting to address the wider family system around a child in a non-specialist context through a different sector, through child protection, in order to improve the reach and to really target those who may be more at risk. The second example I wanted to share with you is the example of Hudwa, which is Lebanon's first national social and behavioral change and communication plan. And I share it because it really addresses the wider macro level, systemic and community level risk factors that we talked about earlier and we found from the voices of our adolescents and parents. Because it aims to address those harmful practices, the root causes of those harmful practices against children, by encouraging and promoting behaviors within the community. So building the capacity of the community to promote the well-being, dignity and equality of children. So again, I've put a QR code here if you want to find out more about this initiative. But to give you some examples, they do things like social and mass media campaigns, social mobilization, community engagement, and building the capacity of the community. And an example of that, there's an image behind that you can see from a beauty salon, was to train people who work in beauty salons or in barbers or in other highly accessed places by the community in parenting practices. And so those promoting behaviors could be included in everyday conversations within the community to shift the social norms and the narratives within a community to build the capacity from within, rather than just at the family or the individual level. So a lovely example of an attempt to really focus on the structural and macro level system levels. Okay, so I will end with just a few words around what do we do from here? What does this mean for us right now in the aftermath of the war? So we know that mental health needs were already high and will be higher. We know that the specialist services are really stretched. And we know that the direct experience of war and displacement, although very harmful, is not the only part of the problem. There's a larger part around disadvantage and insecurity. And so large scale social, community and family support can really has a lot of potential to be mobilized to nurture the healing at that collective level, as well as, of course, the political stability and safety that is so important for a sense of collective well-being. So I will end there just with a question, and I'll open again the participants to ask you whether this rings true for your work, whether the social ecological model and collective mental health is relevant for the work that you're doing currently, particularly for those of you who said you're working with people who have been displaced. Okay. A few. I would love to hear more from you a few more. I would love to hear more from you in the Q&A. And I've also put some references here that I drew on for this presentation in case you're interested. And I think we agreed, so I will stop there, but I will open the floor for questions in case there are questions now, and we'll also have a Q&A at the end, if you prefer to ask then.
So thank you very much, Dr. Tanya, for this very interesting presentation. So for the audience, please, if you have any questions, feel free to write them in the chat box so that we can get to answering them.
questions or comments, because I would be really interested to hear also others' experiences.
Okay, so I guess in the interest of time, we could leave the questions until the end of Dr. Malouf's presentation. So I will hand it over to you, Dr. Malouf. The floor is yours.
Thank you. Does the presentation show? Because I can't see it.
No, not yet. We
Okay.
can see it on your screen.
Okay, just the screen. I think I should share this. Yeah, thank you, Dr. Bosky, for a great overview of the macro system. My name is Fadi Malouf. I'm a child psychiatrist here at the UB. And I'll be focusing more. I want to also thank GHI and Hadi and Dr. Shadi for inviting us to be part of this important webinar. So I'll be focusing on the direct impact, mental health impact on children and adolescents, and also present on the long-term impact drawing from the literature. And because we still do not have, obviously, studies that looked at the impact of this recent war, I'll present some data from Lebanon before the war, the recent war, just for us to all understand the magnitude of the successive crises and the status of the mental health of children and adolescents pre the 2024 war. But in general, and this is from UNICEF, more than 450 million children all over the world live in conflict zones. Refugees and displaced children are 5 times more likely to experience a mental health problem. And the longer the conflict, the more likely and the more profound the impact on the mental health of children and adolescents. And as you know, in Lebanon, the recent war was not the only war. We've been dealing with ongoing conflict that has had successive worsening and crises over the last several years. So if we want to look at the literature, and there are studies that looked at the long-term impact of war on children who became adults later. This is the study from the war in Vietnam, where they followed people for over 60 years. And they looked at their war exposure as children. And the greater the exposure to death and injury and stressful life events in childhood, the more likely as adults, these individuals were to have physical problems, not only mental health problems, chronic physical problems, chronic pain, PTSD, and mental distress. So they really, in this nice article, showed that early exposure to fear of death, to injury, to stressful living conditions as a result of the war had long-lasting impact into adulthood on the physical and mental health as well. And this other study in Sierra Leone, where there was a bad civil war, they followed children who were affected by war for 17 years. And they showed, even 17 years later, these children, now adults, had 50% of them had anxiety and 27% of them had PTSD. So war does not only have an acute impact, but definitely can impact the brain and brain development and manifest in problems later in adulthood. And this is another interesting finding from the 9/11 incident that happened in the US. And they followed children who were exposed to 9/11, and they were between the ages of 5 and 12. And 6 to 7 years later, these children were not only showing emotional problems such as anxiety and PTSD, but they also had behavioral conditions, and they also had more substance use problems than their peers. The prevalence of substance use and behavior problems in these children who were either late adolescents or older adolescents or adults by the time they followed up on them, the more the prevalence of these problems was risk dependent. And by risk dependent, it means that the more affected by the explosion they were, the more likely they were to develop these problems. Affected means, if they were injured, if they had a family member who was injured, if they were displaced, if they were closer to the explosion. And all of these cumulatively would increase your risk down the road, not only to have emotional problems, but also to have behavioral and substance use problems. Children, as my colleague Dr. Bosky mentioned, they don't live alone. They live with a family, and they live within a community, and the school is their main immediate community after their family. And disruption of education is a major indirect also factor that would impact the mental health of children and adolescents, because school is not only a place where children learn. As you know, this is an important place for children to develop their social skills, their emotional regulation skills, their impulse control skills, in addition to developing their problem-solving skills, and etc. So when you disrupt schooling, you definitely leave an impact on the mental health of children and adolescents. But also disruptions of family ties in the displaced population, disruption of friendships, people who also had to leave for different reasons, would have this disruption of the social network would also have an indirect impact on the mental health of children and adolescents. This is the state of the mental health, at least according to the study that we conducted before the war. And this is the national survey on the mental health of children and adolescents in Lebanon. PALS is a psychopathology in children and adolescents in Lebanon study. It was published in 2022, but it was conducted right before the 2019. It was conducted in 2018, so before the successive crisis that happened since 2019. But because it is the only national mental health survey on this population, I think it's important to show you the data even before the recent war and the successive crises. So we were, and this study, we did not use diagnostic tools, we used screening tools. And we screened for various mental health problems. And we did show that in adolescents, at least 45% of them screened for one mental health condition, whether it's anxiety, depression, PTSD, or behavior problem. For the middle age, for the school-age children, 8 to 11, around a third of them had a positive screen. And for younger kids, around 3 to 4% of them had a positive screen for a mental health condition. And I think the rate is low in this population because we did not screen for developmental disorders such as autism and intellectual disability. But I think the most striking finding, which is relevant to post-war interventions as well and response, is that only 5% of children and adolescents who needed mental health help, who were at high risk to have mental health problems, only 5% of them were receiving any kind of help. So we were left with 95% who needed help and were not getting it, never sought it, and were not receiving it. And here I'm gonna open a parenthesis because we have a follow-up finding to look at the reason as to why these individuals were not receiving help. And you would think that stigma is a major reason, but we were surprised to find out that it's not. It's really either lack of knowledge, lack of awareness that they were going through is a mental health problem, or availability and affordability of services. Because as you know, these services are often, people have to often pay for these services out of pocket because they're not covered by third-party payers. And they're also not available, especially in rural areas. And then this is data from Beirut explosion, but it also helps us see who are the most vulnerable and how much of an impact these kinds of events have on the mental health of our children and adolescents. And we did screen a sample. Here we interviewed parents only. We did not interview children. In the previous study, we interviewed both parents and children. But it shows you that at least 60% of the sample had anxiety symptoms that were clinically relevant. A third had depressive symptoms, and half had PTSD symptoms. And that's 2 to 3 months after Beirut explosion. But interestingly, those who were at higher risk were those who were injured themselves, those who had family members who were injured, and those who witnessed casualties. And if you want to look at the most recent war, we can infer that individuals who were mostly affected recently were individuals who had family members who were injured or who were living in areas where they witnessed casualties. During the most recent war, there were several initiatives that were taken in order to support the displaced population. And our department, the Department of Psychiatry here at AUB, took part in a larger initiative that AUB MC was leading to support the displaced population in the schools around the campus here in Ras Beirut. And I want to show you our terrific team here of psychologists and volunteers. The team was led by Mrs. Charlotte Khalil. Charlotte is a wonderful psychologist here at the department. She was joined by Mrs. Jinan Jana, who's also a psychologist with us. A group of psychology interns, Yasmin, Lara, Nergis, Aya, and Muna, psychiatry residents, Dr. Alfred, medical students, Dr. Zahra, a nursing student, Ms. Aya, and they visited displaced populations in 2 to 3 schools around AUB and provided them with support following the following model. So they started with what we know as psychological first aid after receiving a training on this intervention for those who were not trained on it. So there were training sessions initially conducted, and then the interventions were delivered. And as you know, psychological first aid provides immediate emotional support to stabilize and comfort the population. But then these were followed by skills building activities with the youth themselves. And here you can see some pictures. These activities focused on psychoeducation, stress management, and they were interactive in nature. And as these were happening, they kept an eye open to see who's showing a high level of distress. And for those who were showing a high level of distress, they were referred for more individual professional intervention, whether psychological or psychiatric, at our clinics here, OPD, or to different NGOs. And these are statements that were collected by our volunteers, and it gives you a qualitative flavor of what our displaced population was going through during that time. So I'm going to read them for you. I didn't think this is a 42-year-old mom, I think. I didn't think that anyone would care about us, but there was always someone there to listen and support us. A 29-year-old person, the decision to cut my hair because of the lack of water was heartbreaking. It felt like losing a part of myself. A third person, every sound of a plane makes my heart race, and I hold my breath, waiting for it to pass. My child laughed today during the activities, and for a moment, it felt like we were home again. Not being able to play with my son hurts more than the injury itself. This is a 45-year-old who's injured. It's a reminder of everything this war has stolen from us. So, although we did not quantitatively assess the level of distress, you can tell qualitatively from the statements of individuals who were displaced in the area here around us, how the level of impact it had on their mental health and the mental health of the whole family. Shifting gears a little bit, I wanna, my colleague, Dr. Bosky, discussed community-based interventions and family-based interventions. I'd like here to discuss interventions that can be delivered within the school setting and directly with the adolescents themselves. And this is an intervention that we had the chance to adapt to the Lebanese context. It's called Friends, and some of you may be familiar with it. It's an intervention that focuses on building resilience in youth. And for Friends, it's an acronym, so each letter focuses on a certain skill that is taught by the facilitator to the youth. For example, F on focuses on feelings and how to manage and recognize feelings, R on relaxation, I on identifying thoughts, etc. It's a 10 to 12 week intervention that is delivered weekly for an hour. It can be delivered by non-mental health professionals such as a teacher or a coach or a principal. And we did translate it to Arabic and delivered it in different schools, conducted a study in a randomized controlled trial fashion, and showed that it did help decrease levels of anxiety and emotional symptoms in general. But again, this is pre-war. But this is just to show you that, you know, schools is a great place to reach children and try to bridge this treatment gap of 90% that I showed you earlier. We published it here in one of the journals. And lastly, the next couple of minutes, I just want to share with you my, some take-home lessons from responding to different crises and wars of the last several years when working with children. So it's important when you have limited resources to identify the most vulnerable. And how to identify the most vulnerable, I think, by looking at the literature. The literature has taught us that the most vulnerable are the displaced population, are kids who are injured themselves, are kids who have somebody in their family who's injured, are kids who lose a loved one, are kids with a previous history of mental health problems, or whether it's behavioral or emotional. So it's important when you have limited resources to try to identify the most vulnerable and target them with your interventions. As it's been mentioned again, mental health specialists like ourselves cannot do it alone. There is always a shortage of mental health professionals. So definitely there should be partnership with different bodies and task shifting for the interventions to be able to reach as many people as possible. The third point, and I think this is something that we lived through after a Beirut explosion, and we may be living through now after the war has ended. Efforts should last beyond the immediate aftermath of war. Often funders are interested, and NGOs and even academicians like ourselves are interested in the immediate effect of the war itself. And then 2, 3, 4 months after the war ends, funding is withdrawn, interest is lost, etc., and then the population is left suffering alone. It's important strategically to make sure that efforts are sustained for months and even years post-war, because we've seen that the impact can last for, it's a long-lasting impact. It's not just an acute impact. And I think this is my last slide, highlighting 3 additional recommendations. Looking at that pyramid that Dr. Bosky showed, we can't talk mental health before we talk about basic needs. So if the basic needs of shelter, food, medical attention are not met, then really, mental health is not going to be okay. So we have to address basic needs as part of full package of mental health support. It's a challenge to adapt global interventions to local needs. So we cannot just bring any international intervention and implement it here without spending. It took us at least a year to adapt that friend's intervention to the local context. You need cultural, language adaptation. So it's a challenge. But also, developing homegrown intervention is another challenge that requires time and effort, but it's definitely welcome and needed. And beyond healthcare, when you talk about children and probably adults as well, efforts are needed beyond healthcare and coordination beyond the healthcare sector, between the healthcare sector and other sectors are needed, especially the education one, because these kids are going to go back to school. They're traumatized, their teachers are traumatized, and they're going to express their trauma in the classroom and on the playground. And I think I'll end here. Thank you.
So thank you very much, Dr. Malouf, for your insights. So I'll open the floor now for questions and answers. I think we have a question directed to Dr. Bosky. Hala asks, are there additional psychological challenges faced by people who have been displaced for an extended period of time, especially if they remain displaced long after the conflict has ended?
Thank you. That's a great question. And so from research, there's a dose effect over time where the number of years after displacement is correlated with increased mental health difficulties. And then that also has a transgenerational effect. So it can go into second, third, fourth generation. So we see that fourth generation children of people who've been displaced, refugees, have an increased risk compared to their peers of a range of common mental health disorders. So unfortunately, it is something that tends to get worse rather than better. Having said that, there's also research that looks at the mechanisms of why that is. And some of that research, a lot of that research is in high income countries where people have moved from a cultural context to another and have experienced, for example, a lot of racism, being pushed into particularly disadvantaged neighborhoods. So there's an effect of also depending on the type of displacement, the type of exposure and experience, because even just being a minority can be increase your risk of mental health. So it's a complex picture, but it certainly doesn't seem that necessarily it gets better unless the context is particularly conducive for mental health, which unfortunately it doesn't tend to be.
Yeah, absolutely. Thank you, Dr. Boski. We have a question for Dr. Malouf. So Adam asks, what signs can we currently detect when working with children that need mental health support due to the impact of the current war?
So, there are people who are out in the community, kids who are out in the community who are not getting any type of support, and there are people who are already getting some kind of support and seeking it. I can tell you, let me start with the clinic, for example. So what we're seeing in the clinic, we're seeing kids who have trouble because they had to move houses, they had to move schools. We're seeing a lot of adjustment issues. So kids who are trouble adjusting to their new environment, to new schools, making new friendships, maybe being bullied at the new school. So we're seeing a lot of adjustment issues. We're seeing definitely, this is in addition to definitely anxiety and secondary academic issues as a result of anxiety. Kids who are in the community who do not necessarily come and see us, I think people around them should monitor several things. I mean, they should monitor their behavior and whether or not they have more difficulty controlling their emotions, whether it's anger or anxiety. Monitor their sleep, eating patterns, whether they have more trouble sleeping, they're more clingy to their parents, and whether their appetite is changing. Maybe also monitor their interest in activities and friendships, monitor their academic performance. These are all signs, if they're not going well, that the child may be suffering from a mental health distress at least, and they need support.
Yeah, thank you, Dr. Malouf. So we're getting a lot of additional questions. I'm not sure if we're going to have enough time to go through all of them. But there's another question for you also, Dr. Malouf. So Yara asks, how do you see the impact of misinformation or disinformation on the mental health of internally displaced people in Lebanon post this specific 2024 war? Since there's been a significant rise in the use of social media and AI, which have played a role in spreading disinformation.
Yes, and I think we cannot raise enough awareness about the impact of disinformation or misinformation. But add to this, when Israel was targeting civilians in Lebanon, they were using social media to alert them, right? So with the specifics about their targets. So now this is a mean that was used to alert people. It's the same mean that can be used to disseminate misinformation and cause additional distress in people. So it's a very complicated and complex issue, I think. But definitely we need to raise as much awareness about it as possible. And, especially with adolescents, educate them to verify and validate the sources with an adult, or with a parent, with a teacher, etc.
Thank you, Dr. Malouf. So we'll move on to the last question, in the interest of time. And it's addressed to you, Dr. Boski. So Noor asks, do you think the Sawa Aqua program can be applied to refugees who are away from their homes with an unknown return date, and if they were also separated from their families? And Noor also asks, who are the best partners for adapting the program?
Okay, I might not be able to hold all three in my head. You might have to remind me. But those are all great questions. So, firstly, I absolutely is has been used with refugees, and that was also refugees were included in the randomized control trial, so it's been tested with refugees. So, in terms of its relevance and evidence base, it is relevant for refugees. But I think the question was more about if we don't know to what extent they're going to be displaced or whether they're going to go home and when. And so it is a brief intervention. So it takes approximately 6 to 8 weeks. So if it's likely the person will be able to access it for that amount of time, then it can still be used. The 7th session is a follow-up session. And for some families where there are issues around, yes, people leaving, we were able to do the last session or, the odd session online. It's very difficult for family work, but we do have kind of an online SOP to support when it wasn't possible to complete the intervention otherwise. So there are ways around that, but if there's a 2-month likelihood of staying, then it's still feasible to deliver. And I think the third question was around partners. So we delivered it through child protection partners, through TDH, through the Danish Refugee Council, through War Child Holland, also, or War Child Alliance, as it is now. So the psychosocial support, child protection sectors have the setup and the structure to be able to deliver this. We're also looking for funding to be able to do some training of trainers and training of facilitators to be able to increase the reach of the intervention. So that's really where it was designed to be delivered. But part of our next steps is also to see where else could it be delivered? Could it be delivered in through other sectors? And you also had a question about children who are separated from their families. So we included families where there was at least a caregiver and a child. The caregiver didn't have to be a parent, though. So if it was another legal guardian of some kind, we would still include we still included that in the intervention testing, and so there's evidence that it's still effective. It's really about who is caring for that adolescent within the household. That's how we defined what a family was. I hope that answers all the questions.
Yeah, it does. It does. And you were able to hold all three
Just about.
questions.
I went back to the first one at the end.
Yeah. Okay, so thank you very much, Dr. Malouf, Dr. Boski. We're very grateful for your contributions. I just want to inform the audience that this webinar will be, I mean, it's recorded and it will be shared on our social media pages sometime next week. So feel free to revisit the webinar again. I think we can come to a close. Thanks again for everyone who attended. Yeah, have a great day.
Thank you, everyone. And
Thank you
thank you
all.
for organizing, Hadi.
Thank you, Hadi. Thanks, Tanya.
Thank you, Dr. Malu.
Bye bye.
Bye.